Good morning. I'm just adding Shant to the discussion. Just give me one moment. Oh my goodness, people are already joining. Hello. Good morning. And Shant is here.
Hey, we're on.
Yeah, we are.
What's going on, Annie?
What's that?
What's going on? Can you hear me clearly?
Yeah, I can hear you all right. I don't need my
Right. Can
headphones.
you see my model for the day behind
Oh,
us?
lovely. Lovely.
Awesome. Cool. All right.
Um,
Shall we get started?
yeah, look how many people we've got joining already. This is great.
Yep.
Um, Actually, before we get started on the heavy content, what I was thinking is we could just run through quickly. Like I'll talk a bit about when I started working with you
Yep.
and a little bit of your experience as well. So
Yep. Sure.
for anyone joining, and especially for anyone of Shant's followers who are joining, um, I'm Annie, and I've got Ehlers Danlos, and that's an autoimmune condition that causes joint hypermobility. And I've also competed at a pretty high level in powerlifting and bodybuilding. So it's been a challenge my whole life because it's something that you're born with. EDS is something you're born with. It's everyone always says, "Oh, when did you get it?" I'm like, forever. But over the past probably 10 years, if I look back, the sacroiliac joint has been a huge issue for me. And I've been working with Andrew Locke for a really long time and still work with him for some of my joints. But he introduced me to Shant a while ago, who specializes in sacroiliac joint and has done research on tendons. Am I saying that right, Shant? You've done research
Yep.
on tendons, yeah.
Yep.
So um, yeah, that's when we started working together. And Shant and I have been working together for a while. And the cool thing is, I've sent him a lot of my EDS people over the years. So he's really become an expert on hypermobility and sacroiliac uh, joint issues with hypermobility as well.
Yep.
Anything you want to add or just explain a few of your credentials, Shant, especially for my followers?
Yep. So for those are my followers, they know who I am. But for Annie's followers, so I'm Sean. My qualification, my qualification is exercise and sports science. So my undergrad is in exercise science. My postgrad, it's by research. So I've co-authored a few academic journals. So if you just go on PubMed and just type my name, you'll find a few articles.
That's sick.
However, my journey kind of started like similar to yours. Yours started with a condition. So mine kind of started with my own injuries. So I served in the Australian Army for about 7 years, and towards the end of the career, I had about 11 surgeries, and I was medically discharged as a medically disabled person. And just like yourself, Andrew Locke was a massive contributor in that, and that's how I knew that I needed to be somebody I needed back then, and that's
Yeah.
kind of my journey started. And one thing I have always believed in, it's rehab should not just be limited to a very narrow scope. Rehab should be a big scope. So something we spoke about, rehab should not just be rehab, it should be resilience. Meaning strength comes in, movement comes in, all the other things that generally a lot of clinicians would ignore should be considered in that rehab approach. And that has always been my approach. I approach things from a strength point of view, from a movement point of view, and more from a personal point of view. I need to understand the person's story, not just the diagnosis. If you just came to me with an EDS label, like, okay, am I treating EDS or am I treating Annie? My approach is always, I'm going to treat Annie because I need to know what's your story, what's your history, and what your goals are. And that's what I need to address.
I like that a lot. And I think, ironically, that always, so you're saying like you're treating the person, not the EDS, but ironically, that's actually the best way to treat the EDS. Because I think the biggest complaint that people have with EDS, from speaking to my friends and followers with it, is that the doctors, clinicians, physiotherapists, whatever, don't see the full picture. And it's so full picture. And there's so many to this. It's like, I'll go do this rehab exercise. It's like, okay, I can, but there's stairs leading up to the studio where I need to go do them, and I can't walk upstairs right now, so I can't do that. So there's just this whole thing of it's a very complex multi-system condition. So you actually need to take everything into account, but most physicians don't. So yeah.
Yeah, and I'll give you another example. So for example, bird dog is a brilliant exercise to be done on 4, but a lot of my EDS or hypermobile clients, they cannot do bird dog. Now, if I
Yeah.
just focus on, again, the symptoms, I would be like, no, you have to do bird dog. But I know with hypermobility, I'm not just treating one symptom, I'm treating the person. They have a lot of other limitations. And sacroiliac joint injury is one of the contributors in that regard as well. So I can't just give people an exercise because it's a good exercise. I have to understand the person, their history, what they can or cannot do. And I have to tailor everything very precisely to that person.
Yeah, for sure. For sure. I think that's huge. All right, sweet. Let's get started on the questions then.
Sure.
So what we're going to do is we're going to run this a bit like an interview. I'm going to ask Shant questions. He'll answer them and we'll kind of discuss the answers together. But
Yeah.
the first we've got is just an introduction. What is the sacroiliac joint? Where is it? And how problems actually arise at this joint?
Okay. So that's why I have this model right here. So for those who can see clearly.
So in case I put this on the podcast as well. So I'll narrate some things sometimes if you're just pointing to them. We can, in case.
Cool. So what we are looking at is a human skeleton, right? So the human skeleton, generally in clinicians, you'll see people refer to things as upper limbs and lower limbs. So when it comes to upper limbs, we're looking at this part of the body. When it comes to lower limbs, we're looking at this part of the body. What connects that upper limb to the lower limb is sacrum and ilium. Now, this is a joint that is purely connected by ligaments. There's nothing connecting your upper body to your lower body except for those ligaments that sits right in between there, right there. So what we're looking at here is the pelvic girdle, the ring. We have the sacrum, this little bone right here, and we have ilium, one on each side. Now,
So it's like the connecting point between the spine and the hips, basically, the bottom of the spine.
Correctly, it's connecting your upper body to your lower body.
Yeah.
Right? Now, this is a very, very busy joint. You have so many extensor muscles attaching around that area. So you have all your erectors, your lumbar erectors, attaches such as multifidus attaching here. You have your thoracic extensors, all those long muscles, they're attaching here. Your lats muscles, the ligaments of the tendons, they run through here. Your glutes muscle, they come across and attach here. So to understand the magnitude of force that is being transferred, so Stuart Miguel actually measured all the forces that is created by those extensor muscles. And if you add them up, it's 5.6 kilonewton. That's enough to lift a car. That is how important this joint is. That is how much force is being produced just in doing our everyday activity. Right?
Yeah.
So this is something that we need to understand is we're just not looking at the joint. We're looking at all the muscles that are creating forces around it. Okay. Now, the second thing is the joint itself, it needs some movement. It has a very small amount of movement. So previously it used to be thought as a fixed joint. It is not. Because it is connected by ligaments, what we call the interosseous ligaments, meaning the ligaments between the bones, they allow some movement in this direction and this direction and this direction and this direction. So for those following my thumb, opening it up, closing it down, rotating forwards, rotating inwards, right? Okay. So that means we need a very small amount of movement in those joints because we are not uniplane or we're not single direction species. We move in multiple directions. So for that to happen, we need some movement for that force to be transferred to those joints. Now, the problem happens when we have segmental failure. What I mean by that, there is a little bit extra movement than we are allowed. That's one of the hypotheses is that that's what creates the pain. Okay, so if you think about the amount of extensor muscles that are originating in that region, if there's a bit of an imbalance, that can create that segmental failure. And as a result, that is creating the pain. And this is, again, going back to the very first point that we talked about. We are not treating the symptom, we are treating the person. Yes, the pain is presenting in the joint, but we need to understand their lifestyle, behavior, goals, movement patterns that is creating that instability, that is creating that discrepancy, that is resulting in that microfailure, which is resulting in the pain.
Yeah.
I hope
Yeah.
that makes it clear.
Yeah, that does. And I guess the next question then is, how common is SIJ dysfunction among hypermobile and EDS, but also why are they more susceptible to those issues?
Okay, so SIJ is probably one of the most common misdiagnosed
Yeah.
injury, right? So, and we're gonna address that in a minute. However, for true SIJ injuries, I would say let's bench hypermobile and EDS for a minute. I would say in my cohort, 70% would be female that would experience SIJ pain or SIJ injuries. Now, EDS and hypermobility, it's almost every single time I have come across any of their lower limb injuries, it would have some kind of SIJ dysfunction, or it would present with some kind of SIJ injuries or some kind of symptoms, right? Now, the question is, why is that, right? Because you have your hypermobile population that has a little bit extra movement allowed within a joint than non-hypermobile population. So what we talked about before, segmental failure or little micro failure, a little bit extra movement than that is allowed. So within the hypermobility, you actually have the higher risk of that happening naturally, right? That's God's gift to you. You just have a little bit extra movement. So again, we are a little bit closer to the biological tissue threshold where how much you can tolerate. So that's why it's way more common within the hypermobile population or EDS population than the non-hypermobile population. Again, more popular within the female population because of the hip structure than the male population.
Yeah, because I've got quite a few friends and even family and just people I've met with Ehlers Danlos. When I went on to like a Ehlers Danlos group on Facebook and mentioned the sacroiliac joint, so many people like, oh yeah, I get this, I get this, I get this. And I put it as a poll on my Instagram, and people who I didn't even know had EDS were voting on it. And was saying, yeah, I've got Ehlers Danlos and this is an issue for me. So it's just, it's so, my mum has it, my friends have it. Sometimes they don't even realize that that's what it is as well, which is again, something to talk about, because they say, oh, I've just got this pain in my hips and I don't know what it is. And I'm like, oh, I think the clues are pointing towards the sacroiliac joint, the fact that it's mobile. I mean, most people I know with it, with EDS and hypermobility, it's a joint that they've got problems in. Okay, so that actually brings us to what we're going to talk about next, which is if someone who's watching this has hypermobility and they've got some pain, maybe around the hips, lower back, clicking is a thing that people commonly say, I've got this clicking, what is it? What could it be? And they're not sure if this is related to the sacroiliac joint. What are some common symptoms that you would be looking out for, especially in the hypermobile people, SIJ?
Okay, so again, we're gonna put aside the thought of misdiagnosis, right? When it comes to true hypermobility and SIJ dysfunction, the most common thing that you'll notice, any form of unilateral movement will present in some sort of pain, and pain is localized.
So when you say lateral movement, that's like lunges?
Correct. So examples would be walking, lunges, walking upstairs, walking downstairs, walking uphill. Those are the things they will generally present in pain. And if it's a true hypermobility and SIJ together, almost every time it is the 5 to 10 minute mark of walking or walking uphill, they will start presenting with pain and they have to stop.
Yeah.
So that is one of the most common subjective, assessment that you can do with somebody. Like, okay, unilateral movement starts creating pain. It's a localized pain. It's within the, the SIJ location, and that's when it's presenting the pain. Okay. All right. Now, did you want to go to the misdiagnosis bit, or do you want to stay on with this topic a little bit more?
Yeah, I think also just like they get pain when they're doing unilateral movements, but where would the pain be experienced? And like the clicking is a really common question that I've had even since I put up the ask some questions for this live. Clicking up a lot. So clicking, but also the clunking. I think there's a difference between those.
Right. So let's go there for a second. All right. When it comes to hypermobility, again, we're going to go back to that little bit of an extra movement within the segment. So
Yeah.
what we talked about, micro failures or micro movements or segmental failure, right? So that has increased naturally within the hypermobile population than non-hypermobile population. So that is going to be one of the contributing factors. So whenever you're doing any of those unilateral activities, you have to be cautious about it. Now comes the question of clicking. Now, generally, if it was a non-hypermobile population, I would not pay as much attention to clicking if it was hypermobile population. There's a lot of people would present with clicking. It's just a little bit of a clicking here and there. It's just the body adapting to different movement patterns. Sometimes they stay, sometimes they go away, right? It's an individualized approach. But the moment I see somebody who's got hypermobility and they start presenting clicking, I'll be like, that is an orange flag or a yellow flag. It's not a red flag yet, but it's going to lead to something. Now, the location, almost every time the location is going to be there. And it's a very deep pain, and people will respond. It's right in that PSIS or that little dimple that you get in the back of your hip, in that lower back and hip region.
Right? Yeah, which is the point. If I imagine a lot of my friends who've got SIJ problems and I say, well, where are you feeling it? And that's where they just grab onto the hips and press in that spot. Yeah,
that is almost always going to be the location, because the failure is a movement-related injury, or it's a stability-related injury, and it's a localized injury. So you are not going to get referred pain, right? And we're going to get into that in a minute. So the location is always going to be there. The pain generally doesn't feel like it doesn't feel like an electric pain. It feels like a burning pain. It feels like a very deep, like some of the most common thing that I get, especially from the female, is like, I want to feel like I want to punch it. Like it feels so deep. Like I want to punch it and just like, I just want to like do something to it. It's so deep.
That's interesting that you said it's not referred pain, because I've heard people talk about the SIJ causing referred pain, and especially in the groin area. Is that a thing? Not a thing?
That is going to be leading us to the next bit, which is the misdiagnosis. Okay.
Right.
So the groin pain within the hypermobile population. So we have this pelvic girdle, right? So I'm going to go to the groin pain. I'll move away from sacroiliac joint pain for a second, right? So we have the pelvic girdle. So we have the pubis bone here. And right here, there's the pubis symphysis. Just like the SI joint here, you're going to have a little bit of a movement there. Exactly the same type of movements. It closes, it opens, it rotates anteriorly and posteriorly in either direction. Okay. So again, if you have all your adductor muscles and extensor muscles around here working as well, if there is a discrepancy within force production, if there's a dysfunction and creating microfailure and segmental failure, then you're going to have pain in that region. That is more common to hypermobile population. Very rarely, a non-hypermobile population would present pain there, unless it's something else, such as like a tear, or could be a neural referral pain, could be overloading of some kind of adductor muscles or something like that. But microsegmental failure, almost always it's the hypermobile population.
That's interesting. So it's less that it's not so much that the groin pain is caused by the sacroiliac joint, but also presents together with it. Because those two, if they're rotating and doing things, then it's happening at the front and the back.
It is happening at the front and the back. It's not one, they coexist together. They do not correlate, so they do not cause each other.
So coming into the misdiagnosis of sacroiliac joint, is that the main misdiagnosis, or are there other ways that it's commonly misdiagnosed?
Okay, so the most common misdiagnosis is we talked about location of the pain, and that also leads to the misdiagnosis. A common way of clinicians would diagnose sacroiliac joint pain, they will just press at the dimple without understanding the client's history, and they'll go, yep, does it hurt? Okay, you have sacroiliac joint pain. Now, if you can see here all these yellow things right here, right? They're the nerve roots coming up. Again, it's a very, very busy joint. A lot
Yeah.
of your muscle nerve roots that coming out of that lumbar region passes through this, behind this region and around this region.
Yeah.
So a lot of the referral low back related nerve pain would present in that location, especially if you press it because you're agitating a tissue. So you will create the pain. Just because you're creating a pain in that specific location does not mean that is the cause of the injury or that is the type of the injury. So that is
Yeah.
probably the most common diagnosis that I find within the non-hypermobile population. Within the hypermobile population, if they are presenting with referral pain, it can be a two-tier problem. They can still present with SIJ pain because hypermobile population, they have that increased laxity that can create multiple problems. That can create low back nerve related problem and SIJ dysfunction both. So, and this is where understanding the subjective history, meaning the history of the person, the type of movement that causing the problem, the time of the day it's causing the problem, the type of activities causing that function is so important to understand of that person's history. Also the person's life history, like the sports history. What kind of sports did they play? Why did they stop playing any specific sport? One of the most common things that I noticed with the hypermobile population, when they were kids, they stopped dancing because they just kept getting dislocated hips, dislocated knees, because they can't do dancing because of the constant multi-directional movement. They do not have the given stability that is needed.
Yeah. Yeah. Okay. So it's in the non-hypermobile populations, often a false positive diagnosis.
Correct.
Do you think it's ever a false negative diagnosis with the hypermobile populations because people see other things going on and they assume it's not SIJ?
Yeah,
Or
that
is
can happen as well. Yeah, so that can happen as well. So again, a lot of the times what happens with, and this is not a criticism of the clinical population. It's more so, maybe this is the way we are taught within our education system. It's like if there is one problem, we just get fixated on that one problem. We don't look at the whole picture. Right? One of my favorite quotes from Professor McGill: "Everything matters." It means you can present with multiple problems. Within the hypermobile population, thoracic extensor related problem can result in SIJ dysfunction because your thoracic extensors are running from here and attaching right in that region here. And they will start presenting with rib pain as well as SIJ pain. So now I have two injuries I need to pay attention to. Even though they're correlated and they're coexisting, one is causing the other, or maybe not. But we need to understand multiple things can coexist together and we need to address both. We can't just get fixated with one thing. Okay, we just got one problem and then let's get fixated on that. It can also be because of time limitation, right? So my practice, I allow almost up to 90 minutes per client because I understand there's a very specific need of precise assessment. The more precise I can be with my assessment, the more precise intervention I can apply.
yeah.
But if you're looking at a client for 15 minutes, so much you can do within that time frame. So if you figured out one problem within 25 minutes, then you got 5 minutes to figure out a solution for that.
Yeah. And I guess the other thing is like the sacroiliac joint. Well, I mean, we're going to talk about it soon, but just in injuries and pains in general for hypermobile people, there's this ongoing basis of it. Like it's hard to cure these
Yeah.
issues in the hypermobile population, and uh, maybe as well with most clinicians, there's a drop off of people. Like someone will go to the physio for a couple of weeks, and then it's like, okay, I've done my thing. I can
Yeah.
go, but it's, I don't know, for me personally, I think that there needs to be with the hypermobile people an extra focus on, rather than tissue manipulation, for me has never really helped when I've gone to the physio. The tissue manipulation, it might help, even if it does help, it's only a very short-term help, but this is a lifelong thing that I'm managing. So I don't want to have to go back and get tissue manipulation every single week for the rest of my life. The thing that I found a lot more effective is the exercise prescription. So that, which again is another thing we're going to talk about in a little bit, but that's, I think, I guess another thing is a lot of the clinicians who are more tissue manipulation focused, maybe the hypermobile people would be going there, and then after a while they would be like, I'm still in pain. I'm going to, there's high physio drop off rates.
Yeah. And I will go back to the very first question that we discussed. We get fixated on the joint itself and we disregard the magnitude of the muscle forces being produced within that region. It's a movement-related injury. It's a stability-related injury. So you need to be able to produce forces to fix that injury in the right direction. And you need to create those forces to also create stability within that region.
Yeah.
So manipulation generally cannot be the answer. It might be like a very little thing for a very small amount of time to create an opening so you can go ahead and do things as an adjunct, but it's not the solution. Especially within the hypermobile cohort, that increased laxity needs increased stability.
Yeah, we've got actually in the comments section someone with EDS saying, yeah, it's made me worse most of the time when they've had the physical manipulations, which I can attest to as well. Sometimes it helps, exactly what you need, but yeah. Is there anything else you'd want to talk about with this misdiagnosis before we get on to the next section?
Okay, so when it comes to the diagnosis, like the very first thing is your subjective history taking. You have to be very, very good at with your subjective history taking. Be as precise and as thorough as you can be. Get all the information that you need. Try to develop a pattern. And you will almost more than likely going to be noticing all the unilateral movement that are resulting in that type of dysfunction and pain. The second thing is for the clinicians, if you want Lastelet's test and McGill's test, there's some really, really good tests to give an indication whether it's an SIJ-related injury. Now,
is that the
I'm just going to
push them together?
Yeah, so there's quite a few different, so the Lastelet is a cluster of tests, so you need to make sure that you do all the tests to identify, but it also leads to very precise identification of the site and the location and the type of injury. So remember, with the sacroiliac joint, we have movement this direction, this direction, this direction, and this direction. You may not have failure in all directions. It might be one very specific type of direction that is causing the pain. So that's why we need to understand what forces that are needed to be able to counter that failure. Okay. Mm-hmm. So just give you like one example that you mentioned. It's like this here. So a lot of the times you'll have people closing this region, so pushing onto the little bony part of your top hip, and then going for a walk, and that will immediately present pain. For others, what we call the greater trochanter, or the bony part of your leg bone, you press on that and you go for a walk, and then that presents pain. So again, two different types of pain. One is opening, one is closing. Mm-hmm. So that means you need to understand what you need to do to counter that.
Yeah, I remember when I was for one of our sessions together, because I got the sacroiliac joint belt, which is a great tool to use. Yeah. And what we did is you were kind of walking behind me holding the hips at different points, pressing in to see which one of them caused less pain, more pain, to even just to find air on my hips, I should wear the SIJ belt. So it's one of those things that's like, you know, you think, oh, this is a tool that you just throw on and use, but there's even with that, there's the difference between people and difference between how everything presents.
Yeah.
Actually, I'm just going to, we've got one of the comments saying that the manipulations really aggravated this person's pain as well. This explains why. Thank you. I think that's such a, like, it's something that I've known for so long that I forget that a lot of people out there don't understand that the physical manipulations aren't always helpful for people with EDS and hypermobility, because for me, I just feel too loose. I feel too bendy, too loose. And something, it feels okay that day. Normally it's the next day that everything tightens up around it and the pain is caused. Yeah. Another question here. What about the rotational or ASIS moving posterior and other moving anterior? What would the test be?
So I think I understand what that means. It's basically what we're referring to, the other directional movement, which is one moving this direction, the other's moving in this direction. So one of the most common indicator...
Sorry. Quickly for people who are watching the podcast, this is basically like, imagine you're doing a lunge. One of your legs is forward, that's rotating that hip forwards, and one of your legs is back, that's rotating that hip back. So it's this one moving forwards, one kind of rotation.
Correct. So that's we have a contradicting mutation of the sacrum and the ilium, right? So one moving anteriorly, one is moving posteriorly, especially if you're doing something like a Bulgarian split squat with a very, very long stance.
That's the next question that he's asked. Would that be if lunges, crawling, or Bulgarians are
absolutely.
Yeah. So would that be the test if someone is just getting aggravated by lunges that's kind of the only test you really need to know for that? Or would you do further testing in the actual?
I would do further testing. So within the last cluster, there's quite a few different directional force. But generally, once you do enough history taking, you will know which way to go, because there's quite a few different tests, and you don't always need to do every single test. The history will lead to it. So if you know that the Bulgarian split squat or any kind of lunging variation, it's the aggravator, yeah, okay, so that is one of the primary movement. And it can be because of, in some cases, this joint, the hip joint, is not articulating or moving well enough, so the compensation is coming from here.
Yeah.
And this is one of the joys of hypermobility, especially within the EDS population, because it tends to go tight in one area and it goes loose in another area, because this guy right here is trying to figure out what to protect, what to stiffen up, and what to let go.
Yeah. So does this is purely my question. We do have another question from someone watching as well, but purely my question. I've always thought of like sacroiliac joint can't do lunges, because that's a big thing for me. Lunges are a big no. I mean, also because my ankles dislocate as I'm doing them. That's a whole other thing. But the sacroiliac joint is part of the problem as well. Is it possible to get sacroiliac joint problems and the person can do lunges? Because when I'm training my EDS people, that's sort of a test. Okay, if you get pain with lunges, that's SIJ. But could it also be SIJ if they don't get pain with lunges?
So generally, if it's an SIJ related pain, for the first somewhere between 2 to 4 weeks, can be up to 6 weeks, depending on the severity of the problem. I would stay away from unilateral movement, especially closed chain unilateral movement. And I will start introducing open chain unilateral movements, such as kickbacks, right? So one of the variations, I actually need to make a video of this, because I had an hypermobile client of the weekend, and she cannot do on-floor kickbacks, but she can do lying on side kickbacks. So exactly the same principle. You're lying down on your side in almost like a fetal position, and you can do the kickback. So it's only one joint is moving, other joint is fixed. So there's no mutation happening.
Yeah.
So that would be a variation I will start with if I really need them to do, some kind of split squat.
Yeah, I think the key thing there, like the key takeaway for any physiotherapists, coaches, anything watching this who are training people with hypermobility, is the exercise that makes sense doesn't always make sense. And you might give someone something that's relatively low load, but in the same way that someone who's just, got really pain is going to be in pain sometimes just from sneezing or coughing, very low load things, that can happen with hypermobility and Ehlers Danlos, is these things that seem so benign and easy, like you mentioned the bird dogs before. Well, sometimes people can't do them because they can't kneel, pain as well in people. So it's the tiniest things can cause issues, and it can be very different from person to person. I do have another question next to us, but quickly, we've got Zach in the comments has said, can you explain an opening problem and location of symptoms versus closing? And what exactly is opening? Pubic symphysis.
Okay, so if we are referring to opening of the SI joint, so if I press at this joint here, so what we mentioned, the greater trochanter, so if I press here, it opens up the joint around this area, right? So it's almost like a blooming onion, it's opening up. So that's an opening injury.
Yeah.
Pressing it. Closing injury is here. Yeah, so if you press on the dimples at the top of your hip, if you press here, it's closing, so it's creating a little bit of an opening here, but that is one of the aggravators, right?
Yeah.
Now, within the SI joint, it's not a massive joint, so the pain is generally going to present within that region. I'm not so much concerned about the very precise location of the pain, but so much of what movement or what type of force is creating that pain. And then I'm going to come up with an intervention, and I'm going to retest if the pain is still there or not. Or sometimes if the pain is less.
Yeah. Okay, so rather than focusing on the area and saying, oh, this is where the pain is, it's more like, okay, when you move your legs into this position and do an exercise, does that hurt versus doing the position, like using a different position, walking?
Correct.
Yeah.
Yeah, and something again I want to address, like you might have experienced this. Sometimes doing sumo deadlift is good for you. Sometimes doing conventional deadlift is good for you.
Literally, all
That's
it's
a,
people like strong with super conventional. I'm like, I don't have a choice. I do whichever one doesn't hurt.
yeah. So a conventional deadlift would be a closing one, right? So with the conventional deadlift, you're not creating the internal pressure right here. Whereas the sumo deadlift, you're opening this up and it's creating a lot of opening pain. So a lot of people, when they have a lot of opening pain, sumo deadlift will create a lot of pain for them. Not that they're doing anything wrong, it's just like it's not the right movement for them at that point in time. So then they need to switch to conventional deadlift. Whereas in
Yeah.
other cases, the conventional deadlift will present pain like really right there. But when they go sumo, because it now is creating an opening, which is the counter to the closing, they feel better.
Yeah. Yeah. We've just got another comment saying so many physios have given me unilateral leg work to address my squat hip shift, and it has made it so much worse. This makes so much sense. I actually had a client who came, this was years ago when I was coaching out of a gym in Brisbane, and she would drive from Byron Bay to Brisbane just to train with me each week because she couldn't find a coach who understood the hypermobility stuff. She'd fallen pregnant a year or two before, and her coach had given her so many lunges that it triggered this issue in her hips. And there was no one who understood, okay, maybe some of these exercises that everyone just gives out aren't
Yeah.
actually helpful. Which actually we're going to get into some lifestyle stuff as well. That pregnancy thing just reminded me of lifestyle. I think the first thing I want to do before we go into talking about how to actually specifically treat the sacroiliac joint for hypermobile people is just a general overview of how to do rehab, or perhaps a better word is like joint management or pain management with people with hypermobility, and especially Ehlers Danlos. For me, I find like I'm getting the same issues. Like I've never fixed my sacroiliac joint. And I've got this tendonitis in my shoulder, which I've had since I was in high school. And every now and then it pops up again. It's something that it feels like I'm just managing it for the rest of my life. So this ongoing issue of problems with people with mobility, I mean, the source about problems a lot of the time is the hypermobility, which is not going anywhere, right?
Yeah.
Then the other thing is, I remember when we were working together through lockdown, we were doing the sacroiliac rehab. Doing glute training was like the best thing ever. And it was so good. And it was like, I just took my booty bands everywhere with me. And then one day it felt like it stopped working so well. And then a couple of days later, it felt like those exercises were actually causing me pain. And it sent me into a bit of a spiral. Oh my gosh, the pains come back. The thing that helped isn't helping anymore. It's like if you take a painkiller, then one day the painkiller just stops working. Then I came back to you. We actually decided that the opposing movement, so we were doing hip abduction away, and then we were saying, okay, now we're going to do inner thigh work, hip adduction, and that's what fixed it. So this is a really common thing that people with EDS say, and before knowing that this was a thing, it was very discouraging for me because I would find a great rehab exercise, then all of a sudden it would start hurting me, and it felt like I was like, oh my gosh, it sends you into a bit of a spiral.
Yeah.
So can we talk about this a little bit? This is just generally a guide on how to approach pain management, joint management with ED mobility.
So that is actually a great insight into what type of preparation we need to take for hypermobile, especially the EDS population, in contrast to your non-hypermobile population, right? So before we do go with any of the symptoms, the very first thing that we need is precise assessment. The more precise your assessment, it doesn't matter what the injury is, it doesn't even matter what the demographic is. The more precise your assessment is, the more precise your intervention will be, right? So one of my pet peeves, and within my population, everybody agrees, there's no such thing as non-specific low back pain. Everything is specific, everything is precise. I will leave it at that. Now, we need to be very, very clear about how precisely we can diagnose things, how precisely we can understand the dysfunction and what is creating the problem for us, right? That will lead us to the right intervention. Now, within the hypermobile population and the EDS population, this is the challenge that we have. The laxity within the joint is always going to be there. That's why it's a management or it's a maintenance work. Because once you start creating an intervention, it's going to start getting stronger. Let's say with the glutes are getting stronger in this direction. However, you have a little bit of a laxity within that joint no matter what. Once they get stronger past a point, it will create a counter force against that joint that passes the other direction of segmental failure or microfailure, right? So that means this is my problem. I fixed it, but now it's past this region. Now I have to go this region to fix it. So then we have to come up with adductor work.
Sorry, I was just interrupting. It's almost like you're creating another imbalance with the rehab work.
Correct. So you're constantly looking for that equilibrium. You're constantly looking for that perfect balance within that. It's not like you're doing anything wrong. And I always try to encourage my clients, like, do not get discouraged by it. It just means
Good
we
science.
need to be. Yeah, it just means we need to be aware. We need to be a little bit more aware of what's happening with their body. The moment we start noticing changes, we need to address it. We need to address it at that point in time.
Yeah, and I think sometimes, again, not to be critical of the physiotherapy clinicians, but I think sometimes people are the idea of chronic pain, a lot of the discussions in academia and stuff around chronic pain, it's talking about a pain where someone had something happen once, and like a car crash 20 years ago, they've got this ongoing chronic pain. And I've, worked in academic circles. I've talked to academic people. My dad was a GP who specialized in chronic pain. And what I've noticed is that's what the discussion is around often. It's, why is the pain still here? The source of it is gone. And it's this neurological thing that happens in sort of non-hypermobile populations where they've got this sort of reprogramming of their brains. And that's a lot of the discussion around chronic pain. So then you have to reprogram their patterns, their brains, their I don't know the terminology, the technicalities of it, but then there's Ehlers Danlos, which is a whole different type of chronic pain, because it's not like, imagine you bang your head against the wall really, really hard, and it's so hard that it causes lasting damage. The way to treat that is rest, give it time, maybe give it some medicine, maybe some stitches, and then you'll get better. But with EDS, we wake up every day and we bang our head against the wall every single morning. It's an ongoing thing. The treatment looks very different. Every time we move, we're triggering the thing that causes the pain, because it's the laxity in our joints and the dysfunctions that result in our movement as a result.
Yeah.
So when I'm talking to people in the academic medical world with chronic pain, I often say it's more similar to cancer pain, in the sense that it's constantly there and it's constantly arising new every single day. But I think that the clinicians have this idea, it's almost like they were taught that pain is something that arises, then you fix it, and then it's fixed. Most people, that's how physiotherapy should be, right? Like for non-hypermobile people, if you get someone coming in, it's a bit of a stitch up if you get them coming in every single week after week for the rest of their life, if the problem can be fixed in the first couple of sessions. But with EDS and hypermobility, it can't be fixed in the first couple of sessions.
It's a lifestyle, and it's a maintenance or a management challenge rather than one-time fix challenge. And one more thing I actually wanted to address within that hypermobile population, it's and this is more going to be for the clinicians than the clients, but the clients, you guys can chime in as well. So think about, so this is the spine, right? So we have a vertebral body, we have another vertebral body, so two bones and the disc in the middle. So there's a theory called Punjabi's neutral zone theory. Punjabi's neutral zone theory originally applied to the low back region, but it actually applies to a lot of other regions, especially for hypermobile population. What it means, within this joint, I have X amount of movement. That is the neutral zone. Mm-hmm. If there is a tissue failure, it increases the instability, hence it increases that neutral zone, means the movement has increased. Now I have a little bit more movement and a little bit more laxity that is leading to that movement. Within hypermobile population and the EDS population, you already have that increased neutral zone. That means you constantly have to stay vigilant to maintain that stability, irrespective whether you have pain or not.
Mm.
And this is where good coaching comes in, constantly paying attention to your clients, how they're moving. You want to catch it right before it happens.
Yeah, yeah, that reminds me of actually early days when I first started working with Andrew Locke, and he would come to the gym that I was working at, treat a lot of our clients. And a big thing of his is getting people away from being obsessive about injury. And I can't do these things. I've got to be obsessive. And, like when you get the injury, this is in non-hypermobile populations, when you get this injury, then fear of using that area. And if you hurt yourself deadlifting, you're scared to deadlift again. And a lot of his stuff was kind of coming from the perspective of, okay, let go of this fear, let go of this hypervigilance. We need to get back to normal functioning. And then he turned to me and he said, and I said, oh, okay, does that apply to me too? And he's like, no, you have such little margin for error in your technique. You have to be hypervigilant. And I see all this stuff online, there's the industry always swings in these big pendulum swings, and there's been this huge swing towards technique, perfect technique, and now people are starting to swing away and saying, no, we need to put in effort to the sets, stop being so obsessive, don't major in the minors. But for us with EDS, technique is not a minor for us to major in. It's a big thing, using correct movement. And I think that I love strength training as a treatment for people with EDS, as an ongoing management, especially if you take a very full body kind of bodybuilding approach. Like my body feels great with that, because bodybuilding is all about balance and proportion on the joints. So rather than being reactive and, oh, I've got this pain, I better figure out what's wrong with it and fix it. Oh, I've got this pain, I better figure out what's wrong with it. You're just sort of saying, I'm going to train everything and everything's going to improve. And fewer pains will arise. And the difficult part of that is with EDS hypermobility is a lot of the time when they start training or before they start. So for me, I've just taken a lot of time off and I'm getting back into training. The pain is stopping me from being able to do that. So that's when I come in and I call up Shant and I say, please help me. I really need help. I've got no idea what's causing this pain. Then we work on it and get over the pain, because my goal is to be able to do the bodybuilding training to prevent the pain from happening. But it's a bit of a catch-22 sometimes. Yeah. I'm just seeing we've got some comments I'm seeing. Zach saying, can you please state that theory? That was the neutral zone theory, I think.
Yes, it's Punjabi's neutral zone theory. There's a first paper was published, I believe, is in 1991. So if you just type in Google PANJABIS, Punjabi's neutral zone theory, a whole bunch of papers and maybe some explanations will come up there as well. But I'm making a couple of notes. I'll make a post about that as well.
And we've just got another comment which has really triggered me. Doctors have been telling me that being bendy doesn't matter because lots of people are bendy. That makes me so mad, because yes, lots of people are bendy. Between 10 and 30% in one study is what I read. Between 10 and 30% of the adult population are hypermobile.
Yeah.
What this means is not that it doesn't matter. What it means is that it actually really matters. If, I don't know, 1 in 5 people were dying at 20, you wouldn't just say, oh, that's okay. A whole bunch of people die young. It's fine. Like, no, why are these people dying young? So doctors are just looking at this so wrong. This is something that actually more people need to understand. And I'm so glad that there's physios and personal trainers and coaches in here, because this is something you need to understand. If let's say 1 in 5 people are hypermobile in the adult population, I have worked with so many people over the years who've come, they've said, oh, my coach couldn't fix me. They told me I was a lost cause. They told me that it was all in my head, that the pain was all in my head. I'm like, okay, let's have, and I look at them and I say, oh, well, your joints kind of bendy. Yeah. Oh, wow. Look at your fingers. They can bend back pretty far. Okay. Have you ever had dislocation as a kid? Yeah. Okay, cool. Then they might indicate some symptoms of sacroiliac joint pain. Oh, I can't walk for long periods, and I think walking's such an easy thing. Why can't I do it? I'm like, okay, this is starting to look like hypermobility. I ask, do you have like sensitivities to allergies? Some of these other Ehlers Danlos symptoms. Sometimes it's like, oh my gosh, you've got really bad hypermobility and probably bad Ehlers Danlos as well. This is not all bad. It just requires a different approach. And the the lack of knowledge around what that different approach is frustrating for me, but more frustrating for these people. So I give them a few tweaks, a few changes to the cues. I tell them, don't go for long walks, like just some small changes, and their results improve dramatically. And I think that is something, you know, I have a lot of people who follow me because they say, oh my gosh, you still lift weights, you can still do all this stuff. First of all, it comes with a lot of work to be able to do this. But secondly, I think that the biggest thing that has helped me is being mentally flexible with how I approach training.
Yeah.
And it's okay if I don't do it the same way as everyone else. It's okay if I take a different path, because it is needed and more people need to understand this. I've been saying this for a long time. I think this is going to be one of the new sort of buzzwords in the fitness industry that people start looking into, the hypermobility, and I think it's overdue, especially now that there's more research coming out with the link between neurodivergence and hypermobility. You know, there's been a surge of people getting diagnosed with ADHD and autism, and now they're starting to talk about, okay, well, I'm getting these pains. Is this normal? No, it's not normal. This is linked to hypermobility and something that you can manage. You just need a better approach. Which is why I was so excited to find both Andrew and Sean, because they listened to me and I said, this feels bad. Is that normal? There's an explanation for this. So that's a big frustration of mine, that people not understanding the hypermobility.
Yeah, completely.
So we've got a question. What are some other questions you would ask to raise suspicions around EDS? So one of the big ones is allergy sensitivities, because, you know, some people would actually describe EDS as a histamine disorder. There's all these different lenses that we can look at it through. We can look at it through autoimmune. We can look at it through histamine disorder. We can look at it through pure collagen disorder. Another big one that I would ask about is, what's your circulation like? When you go into cold, do your hands sort of just shut off and stop working? Does your skin go purple when you press it? Do you have lines there? That's another one that I would ask. Then I would probably mention the neurodivergence, because there is a crossover with that. Positional issues. Do you get, you know, I've had clients who can't do bench rows because that positional change makes them dizzy, or you know, with EDS, something I struggle with a lot is the fluctuating spinal fluid pressure. You find sometimes you get headaches from lying down versus standing up. The POT symptoms is big. So postural orthostatic tachycardia syndrome. It's basically where your heart rate really regulate itself properly. So people with EDS, they'll start doing some exercises and their heart rate will just shoot through the roof. So if you're a coach who's watching this and you're monitoring heart rate and you're like, oh my gosh, what's happening? That's a POT symptom. The dysautonomia, well, is another big one. So that's linked with the POTS, but basically dysautonomia means dysregulation of the autonomic nervous system. So the things that we do without thinking, breathing, our heart rate, our sweating, night sweats is a big one. All of those things that we do without thinking. That basically, I'm not an expert. I'm not a doctor, so I can't diagnose these people. But what I'll say is, okay, this means that we need to take a very careful approach with your. But this is, like you said, Shant, like at the start of working with anyone, you're doing such thorough analysis of them that you should be finding this stuff out anyway, even if you don't know about EDS. But knowing about EDS gives you the lens to look at it through, to understand, okay, this is the pattern, the way I should treat this, the pattern. And unfortunate thing is most physios, doctors, personal trainers, coaches don't even have this lens to look at it through. They don't understand that it's a thing and that the symptoms seem so weird and random, and it can result in people really, oh, it's all in your head. Oh, no, I don't know. That seems like nothing. This is actually symptoms to look out for. Okay, just some comments. Someone saying vertigo. Yes. Can we touch on the link between EDS and POTS? I had a mysterious fainting thing as a teen. There is a link. I don't know enough about it, but I've got a very good friend who is a very smart academic who works in researching Ehlers Danlos herself. I can do some more stuff on that. A link between low blood pressure, believe yes, and I think it has to do with the hyperflexibility of the blood vessels themselves. But again, I don't know enough about this. Shant, do you know anything about that?
So with the blood pressure, again, it could be something we talked about, the vasoconstriction and the vasodilation. So there is a correlation between EDS, not necessarily hypermobility. So the EDS, you do get that a little bit because your vasoconstriction and vasodilation can be a little bit, let's say, outside of the acceptable parameter. So it can affect your blood pressure. Yeah.
Yeah. Yeah. And I think the blood pressure can come from the fragility, like the venous return is affected because of the tissue of the blood vessels themselves, but also with the dysautonomia, that can change the way that the body is regulated. And it's really interesting.
Correct.
I have a gastroenterologist who specializes in Ehlers Danlos, and someone he has mentioned the food intolerances, that's a big one as well. And the gastroenterologist, I always just assumed that all of my gut symptoms were because of the tissue being different, as in like the collagen that, because Ehlers Danlos is a collagen disorder, so maybe the collagen that forms my stomach wall is faulty. But his discussions with him basically indicated that a lot of it was nervous system related. So yeah, the dysautonomia actually causes a lot of the stomach problems. So yeah, anyway, that was just a big rant that I went on, triggered by one single thing. Let's talk about so we've talked about generally with Ehlers Danlos, it's an ongoing thing. You're not going to cure the issue, so don't feel bad about yourself if you can't. You do want to find things that feel good, and I think that's a really good general tip for coaches, personal trainers, whatever, is if a movement feels really for the person, that's probably a good thing to do more of. Avoid the things that cause a lot of pain, obviously, but this rehab approach will change over time. So you might have someone who can do a movement for a while, then all of a sudden they can't do the movement. You need to follow what their body is telling you rather than saying, you should be able to do this movement. You used to be able to do it, so it's fine. So let's take this now away from general joint stuff and getting into specific sacroiliac joint management. And we've actually got a question here. Can Shant get into recommendations on how to manage things? Yes, that's what we're doing right now.
Yeah.
So for me, I find it's a two-pronged approach with my SIJ stuff. The first thing is avoiding triggers, which I think is big. And a lot of people, a lot of clinicians aren't necessarily thinking about this or aren't aware of all of the things that could cause triggers for people with EDS. So for me, one of the big ones is my bed, my mattress. When I was doing bodybuilding, it was my bodybuilding posing. Sometimes it's deep squats. Sometimes deep squats are okay. Sometimes it's lunges. And when I'm on my period, it gets a lot worse, especially like the week of my period, the week before as well. So the first thing I do is avoid triggers. But then the second thing I do is the proactive exercises to actually, what everything Shant was talking about before, create stability and strength around that region. But let's talk about the triggers first. What are some common ones that you've seen, and what suggestions would you have for managing?
So I'll go back to the history taking. So when it comes to the history, again, you will find the aggravators. If you take a detailed enough history, you will know what are the things that aggravates them and what are the things that do not aggravate them. One thing I actually get my EDS and hypermobile clients to do have a pain diary, not necessarily because of getting fixated on pain, but the movements or the patterns or the functions that lead to pain. And you will notice, like you said, some things feel good at one point in time and those things feel shit at another point in time. The first thing to do, stop if it's hurting. If you're in pain, don't do it. It's just not the right thing to do right now. We will figure out why it's hurting. And sometimes it just means that you are going through a transition process where you're just not allowed to do that at that point in time. That's very specific to the EDS population and some high range hypermobile population, right? It's very rarely I will tell people not to do things. So I will always look for answers like, how can I get you to do things? But within the EDS population, so one example comes to mind, you squatting deep or creating pain. You can still squat, but half squat. That's what he can do, then that's what he can do.
It's frustrating. And the other thing I think on that is the pressure, the external pressure to do things how people think you should do them. So
Yeah.
I would only ever, like, it's really hard for me to find a coach who I can trust and work with because they want to say, well, you should be able to do this. Let's get you doing it. Like you said, Sean, that in most populations, that's actually a great approach for the coach to have. Let's find a way. But for me, it's like, no, I just can't. And also being aware that weird things can be triggers. So, yeah. But anyway, sorry,
Yeah.
continue.
Yeah, so, and the other thing is, especially within that menstrual cycle phase, I will avoid unilateral exercises just as a general rule. Like,
Yeah.
don't do any kind of lunges, split squats, walking up hills, those kind of movements, or stairs. Cross trainers is another aggravator, because a lot of the clients that love doing their cardio, and cross trainer is a great exercise, but during that phase, it can really aggravate because it's in a fixed range of motion. So if there's any kind of discrepancy, it'll just keep repeating it.
Yeah.
So that's one of my management plan, right? Menstrual cycle, stay away from unilateral movement, focus on more bilateral movement.
Yeah.
You can do things, if you can do things in a shorter range of motions, do that. Don't get discouraged that you can't do osteograss squat. If you can do a half squat, do that. If you have to do rack pulls as opposed to do a full range deadlift, do that. Because it's just not right now.
Yeah, there's a thing I like to say is just because you can't do it now doesn't mean you'll never be able to do it. And finding ways to perform a version of the movement pain-free, whether that means reducing the weight significantly, reducing the range. I've done like auto movements before, and I'm like, you know what, this is all I can do. And that approach, people say, how did you get to compete at such a high level in powerlifting? That approach. And I think that the two things that I would say here is, one, just because other people are doing it a certain way doesn't mean you have to do it that way. With EDS, your path will always be different from normal or non-hypermobile people. It will always be different. But don't look at those people. When I was competing in powerlifting, I remember I had to train really submaximally. And actually for squats, I couldn't even squat in my training. I squatted for the 3 weeks coming into competition, and I hit PBs every time. That's how I hit my best squat. 185 was 3 weeks prep on squats because I was training all the other muscles to get strong in all of those muscles. I was doing lots of mental rehearsal of the squat movement. And I just couldn't do the things that other people could do, but I still won the competitions. Just because you have to take a different path doesn't mean your destination can't be really great. The second thing I say is the triggers are weird. I sit down with my EDS people and we have the weirdest triggers, and it's the kind of thing that you just find your people when you have these conversations. You know, one of the things is toast. I can't eat toast because it cuts the roof of my mouth. I will never eat a toasted sandwich because it's too dangerous for me. The bed is another one. I actually, when I house recently and I had to get a new mattress, I ended up doing the smartest thing I think I've ever done in my life, which is getting a couple's mattress. One side's hard, one side's soft, so that when I fluctuate, because all of these symptoms fluctuate, it's not just, oh, which exercise you can do that helps fluctuates, it's everything. When I was living previously in Sydney, I remember I'd move house quite regularly, but every time I moved, I had to buy a new mattress because this one was perfect and it fixed all my pain. And 6 months later, it was the source of my pain.
Yeah.
I got a really hard one, and that was great until it wasn't. And then I had to switch back and get a soft one. So I got this couple's mattress. One side's hard, one side's soft, and I just roll between it. Based my back feels, and sometimes it takes me lying down on it and thinking, okay, is there like within 10 seconds pain? And then I'll switch to the other side. Is there within 10 seconds pain? Okay, I know which side I'm sleeping on tonight. And I know, Shant, you recommended a mattress that's adjustable, the Yakuza
Correct.
one.
So, like dealing with so many of the hypermobile population as well as the EDS population. So, one of the things I always recommend, and at one point I thought maybe I should start getting commission from these mattress companies because so many of the clients that I had referred to, they're like, oh my God, these mattresses are amazing. Right? It's like it has 3 different layers and you can choose which layer you want to do. So again, there was a question about how did you resolve the mattress issue? You do not resolve the mattress issue, you maintain the mattress issue, right? It means sometimes the medium strength is going to be the one, sometimes the stiff one is going to be the one, sometimes the soft one is going to be the one. So when you get those mattresses, I think the brand that we were talking about, the one I really liked was Ecosa, the brand. Again, no affiliation with them. I just really like the fact that they have a mattress that has 3 different layers: hard, medium, soft, and you can choose whichever one you want at that point in time. I didn't know about the couples one, but when I heard from you the couples one, I'm like, hey, that's a great strategy. Because especially even if you have a partner, then okay, sorry, sweetheart, you're gonna have to sleep on the right side today. You know.
Yeah. And I got Sleeping Duck. Sleeping Duck is expensive, I will say that. But the Ecosa one, the only thing for me is, even though I'm strong and fit, sometimes I don't actually have it, like the awkwardness of adjusting the layers is difficult for me. And I don't have someone else sharing the bed with me other than my dog. So it's fine. But I got Sleeping Duck and I got medium and hard. And they do now make a customizable one where you can actually take out segments of the bed. So you can have it hard at the top and soft down the bottom. And it's really good and adjustable. My bed is just like, nobody could ever share my bed with me because I've also got it on a slant because of my
The CSF pressure.
CSF pressure. So
Yeah.
I'm on my head up here. And yeah, it's just a very Ehlers Danlos kind of bed, but that's fine. But yeah, coming back to the point that we're saying here, the triggers are weird. Posing for bodybuilding, everyone says, oh, I get a bit of back pain. I'm like, I can't walk after I pose. So I need to do all of my activation exercises before I pose in order to even do walking. Everyone thinks that walking is just this safe thing for everyone. No. With EDS, it got to the point with my bodybuilding preps, I physically couldn't walk. And I still had to do my hour of cardio. It was like, how am I going to do this? And my coach was like, okay, we'll get you on the hand cycler thing. Well, I can't do that either because I've got the hypermobility in my shoulders. I can't do this. So it was all of these chasing things around. But then I talked to someone with EDS and they just get it. That's where this invisible illness comes in. If I didn't have a leg, if I had my leg amputated above the knee, nobody would ever say, oh, why can't you walk on 2 legs? Because it's visible. But with EDS, and the triggers are weird. So I encourage you, if you've got EDS, talk to your people with EDS and discuss the triggers with them. It'll make you feel a lot more normal. And if you're a clinician or a physiotherapist or personal trainer who works with people with it, talk to people with it and listen to them. Listening is probably one of the biggest things. Someone's just said, what's the symptoms of CSF pressure? So this is not my specialty, but it is something I experience. So headaches, tension headaches, they're made worse with lying down. So if you've got low pressure, which some people do with EDS, lying down will alleviate the headache a lot of the time. If you've got high pressure, lying down flat is going to increase the pressure. So the pressure does fluctuate. Tension headaches, dizziness, like a worsening of those sort of spacey symptoms, depending on whether it's, again, high or low pressure. And if it gets really bad, if you've got high pressure, it can leak out the nose or into the spinal cord or whatever, or spinal cord area. But that's something that, again, I'm not an expert on, but it is something to talk about.
And if I may add one more thing, again, what we discussed in Gold Coast was the CSF pressure within the spinal canal, which can give us, again, a false positive of neural pain. It behaves like a discogenic pain, but it is actually not. So whenever you have CSF, which is the cerebrospinal fluid, within the canal, so you have all these little nerves running through that canal. When you have the pressure increased, it creates constriction around those nerve roots, and that behaves like a nerve pain. But you cannot put a pattern to it except for whenever and this is how I found out about it. It's whenever they say, like, especially I learned that from you, it's like, oh, I had like fluid coming out of my nose. So whenever they start saying things like, I start getting so much headache, I can't just stand up straight for a bit. I have to sit upright and lean back. And then I also, at the same time, I start getting back pain. Like, okay, so I've done all the mechanical tests that's saying you do not have a discogenic or flexion intolerant pain. But you are getting all of a sudden out of nowhere in these little segments of nerve-related pain. What means that the vasoconstriction has increased because of the hydraulic pressure within that canal. And one of the solutions that we have is Find about roughly 1 meter deep water, and then just go in there. Don't go into the ocean like we were there. It was pretty choppy. It's not going to be good. Go into
Okay.
the pool
I think
roughly, roughly about 1 meter deep water has the same level of, hydrostatic pressure that can alleviate that pain. So just going into the swimming pool about a roughly meter deep, just move around for a little, even just sitting there for a bit, you'll notice that the pain actually alleviates a lot more.
Yeah, if you were to go to a doctor, it's very hard. The CSF pressure thing is very hard from the perspective of going to see a doctor, because the tests for it are, there's a high chance of a false negative test, because they'll do a spinal tap, which is a very confronting test to do anyway. If you can convince the doctor to do it, it's a very confronting test, but there's a high false negative rate. But one of the management things that they can do is prescribe diuretics. So that's something that without a doctor prescription, again, this is not medical advice at all, this is how I manage mine, is with diuretic tea. So when it's bad, I drink that. But that comes with complications as well, because then it's like, okay, at what point of you is the pressure going too low? Like I was talking to a friend of mine, yes, and she said, yeah, she's got to be really careful, fluctuating, but when it's high, if she does all of the things that make it low, it might go too low, and that causes problems. So that's why I really like your idea, Shant, of just submersing in water. And I also just really like this piece of information that you gave me, because it's so easy when there's weird symptoms and they don't make sense to just say, well, it must not be real. But it actually is. It's just different from what people are used to seeing.
Correct. And those people, you get them to brace hard, and it will make their pain worse. It doesn't matter which direction you're bracing. Just bracing is not going to work for them.
Yeah, this is explaining a lot as well, because that increases the pressure. Yeah.
Correct.
Yeah. Oh yeah, another management thing I do with my spinal fluid stuff is avoid exercising high pressure lying down. So I can't bench press or anything close to lying down, which is a complication again with EDS, because these people, we often need a lot of core exercises, lots of bracing. But when I have high pressure, I can't do a plank, because the bracing causes the increase in pressure, and I get a migraine from it. So that's another consideration. If you're a clinician or PT or coach working with people like this, that's another consideration. So we've talked about this now with the SIJ, how to manage the SIJ specifically. Avoid triggers is number one. And that's bigger than a lot of people realize, because the triggers for people with EDS and hypermobility are so, they're always there. And they can be really weird and unrecognizable to the non-trained eye. But the second approach that I will say is, and we need a two-pronged approach. It's not, you don't just avoid the triggers and then not do any proactive exercises. But also, if you do all your proactive exercises and you're still not getting results, it might be because you're literally exposing yourself to the trigger every single day. So we've got avoid the triggers, do proactive exercises. How do we approach these exercises? How do we take a proactive approach to stabilizing the joint from a muscular perspective? Obviously, we've mentioned the sacroiliac joint belt as well, which just holds everything together nicely. But from like the perspective, how do we do this?
Okay, so think about all the mechanical forces that are going through within that region to stabilize it, right? So the key thing here is to stabilize that joint and mobilize what should be mobilized. What I mean by that, this needs to be stable. This needs to be mobile. The more we can stay within that spectrum, how we do that, it's going to be different at different phases of the maintenance phase. However, the goal is to stabilize that SI joint, mobilize the hip joint, meaning even if there's a case of failure, I still managing all my movement out of my hip joint and not creating any kind of stress on my SI joint. That's going to be the number one. So, for an example, one of the exercises that I use is like a skydiver with the armpit squeeze, because your thoracolumbar fascia of your lats comes right across here, and your glutes comes across here. So it creates a forced closure. What it means, it creates force from this direction and stabilizes that joint. I'm taking away those microsegmental failure, a little bit of a movement away that can trigger the pain. So that's one of the active way of doing things. Now, one of my favorite, I generally do not recommend for non-hypermobile population to be reliant on an equipment. However, when it comes to SI joint, the Sacroiliac belts, again, no affiliation with it. These guys, they make the best SIJ belt. I have not found another company that makes a belt as good as this. Now, if you have EDS or if you have hypermobility, especially high-end hypermobility, you have to have this belt handy. It's not that there's something wrong with you. You're just going to go through phases where you're going to need them. So even if you're doing all the right things, you're still going to need them. Now, the second part is, where do I put the belt on? So this is one of the most common mistakes people make. Now, if you remember, we went through assessment. If I press here in the ASIS region, or the dimple part of the front of the hip, it can create opening. A lot of people make the mistake. So if you put hand at the front of your hip, like right here, you find the dimple. And a lot of people put the belt right on top of it, which is actually aggravating the problem. And those are the people who say, oh, I've used an SIJ belt and it made my problem worse. It's the location of the belt. So if you're putting the belt here, all you're doing, you're actually recreating your pain mechanism. Think about where your SI joint is. So PSIS are the dimples of the hips right there. The belt needs to go here. So I always recommend people put the belt from the back to front, not front to back. Find that little, that's why the belt is so narrow. It's not a big, it's a thick belt. Put it right here and then go around, and you'll notice it sits like right underneath that.
So it's quite a lot lower than what people think about. When I used to do mine, I'll just stand up so people can see. When I used to do mine, I where the crease of my hip was and put it just above that. Often that was the spot for me. But again, sometimes I needed it higher up. Sometimes I needed it lower down.
So you might have to make subtle adjustments where you feel good, but never really high up where you actually feel like, oh, this is that little bony protrusion part of the front of my hip. Never put it on top of that. It will create some problem for you. The top of the belt should be right underneath it. It can be touching it, but not on top of it. So that's one of the proactive management thing that we can do. Now, the other protocol of the belt is, it's not an on and off thing. If you're going to put it on, leave it on close to 24/7 for 2 to 3 weeks. Because the point of the belt is to decrease the laxity so that the ligaments within the bone can get torn. So that's what we're trying to achieve. So you need to have the belt on full time so the ligaments can do their job of getting torn again without any kind of stress.
So that means during training, during sleeping, during walking, during, I used to, I know some people as well, like again, coming back to getting your period, and that was the ring of the pain, people would sort of proactively wear their belt coming into their period. That's like a really helpful sort of thing to do. And also, so if you've got triggers, is that? So if I'm like, let's say I get pain walking my dog, which I do, is it better for me to sort of wear it all the time, or is it okay for me to just put it on for my high trigger activity? Or should I say, do what you've said there and wear it all the time?
If you're going to put the belt on, the belt is effective for a consistent prolonged period of time. So for the ligaments to get taut, the minimum time is about 14 days. So you need to leave it on for about 14 days. It's kind of like, you have a scab, it's healing, but every now and then you just want to pick it a little bit. You're just delaying the healing process. So if you leave the belt on, just leave the belt on and let it do its thing, and go on with your everyday activities.
Yeah, and I got one of the Sacroiliac belts based on your recommendation, and it's so much better. I got a cheap belt on day, and it was just so bad. Again, with the Ehlers Danlos, there's so many other things to think about, because it would cut into my skin and it was bruising on the skin because it was too tight, but the Sacroiliac belt
Yeah.
distributes the force on your
And
body.
if you can see, that's the design of the Sacroiliac belt. Again, I have no affiliation with these people, right? I just like it because it's a very good design. So you can see there's a bit of a soft foam component.
Yeah.
So this bit does not dig into your bones or your skin.
Yeah, and you can adjust it easily. So you sort of put it on, and then you can adjust the side bits to make it tighter or looser, which is just great.
Yeah.
So that's the belt. Let's talk about some of the exercises. I like what you said before about incorporating the lats in. Is there any particular muscles that you would look at more often for people with hypermobility managing SIJ? So lats.
So when it comes to hypermobility, like I said, I look at more the movement rather than a muscle. Non-hypermobile is a little bit different. I will say, okay, if glutes, then glutes are the problem. I will address whatever the function of the glutes that is failing. But when it comes to hypermobile population or EDS population, it's the hip joint. So in your case, we had to train the sartorius muscle to counter the glute muscle, because sartorius muscle create external rotation inflection, very similar to glutes. So I'm looking at, again, what I mentioned, I'm looking at the articulation or the movement of the hip joint. And this is that maintenance work. How am I going to get there? Sometimes it's going to be the glutes that's doing the work. Sometimes it's going to be the psoas and the sartorius that are doing the work. So, the banded inner work, I think in your case, I had to do it lying face down, and then like a reverse bench like lock clamps. So those are the two approaches we had to come up with.
Yeah.
So the glutes were doing its job really well for 1 minute, and then in about 6 weeks or 7 weeks times, we had to change it again to the internal rotation dominant movement, but we're still creating external rotation at the hips. So it comes down to the movement of a particular joint we are trying to address rather than one set of muscle that we're trying to address. You're constantly looking for the right movement, but you're getting there with multiple directions. So like we mentioned before, it's never one tier approach. You have to come in from both directions. Sometimes it's going to be the glutes, sometimes it's going to be the psoas and the sartorius.
Yeah, there's this really interesting thing. So I was writing an anatomy textbook for someone a while ago. And I came across, when I was doing some research, I found this guy who was talking about this idea that I haven't really heard anyone talk about very much. But this was this anatomy professor at an American university, and he was talking about how, there's agonists, antagonist muscles, there's stabilizing muscles. He talked about this idea, I think it was neutralizer muscles. So if you're doing an exercise that's working the glute maximus, for example, the glute maximus is an external rotator, an abductor of the hip, and an extensor of the hip. He was saying that the role of neutralizing muscles, let's say you just want to do hip extension, the neutralizing muscle counteract the external rotation or the abduction that muscle has a tendency to perform. Right. And I don't know, I went to look up and find other people talking about this, and I just couldn't. But I was like, this makes a lot of sense. And I think it could also play into this discussion that we're having here where, I always say with an Ehlers Danlos body, if something can go wrong, it will. When we're doing an exercise, if there's a way to do the exercise incorrectly, the EDS body will find a way. It's doing very small exercises that you can't possibly do wrong, and then building bigger ones, teaching your body how to move properly before you get to that point, and using braces or bands or physically guiding the body to make sure it does it right. But have you an idea of the neutralizer muscle, or do you think it would play into what we're talking about here?
Look, I'm not familiar with the concept of neutralizing muscle. The way I see it, it's you have stabilizing muscle, and then you have your, the movement muscles, right? So, for an example, your stabilizing muscles, something like multifidus can be a stabilizing muscle, can fall into that category. Yeah. So, if something is stabilizing something, it allows another thing to mobilize. Now, human body is built in a very stability and mobility stack. So if you think about your hips, it has a lot of movement in multiple directions, but your knee has only one directional movement. Again, your ankle has multiple direction, but your metatarsals, they only have one direction. They do not rotate. So stability, mobility, stability, mobility. Same thing. We have very limited movement in the lumbar region, but we have a lot of movement in the thoracic region. We have a fixed shoulder girdle, but we have a very mobile neck. Like I said, a little bit out of the picture. Same way with the shoulder. We have a mobile shoulder joint, but we have unidirection elbow joint. We have wrist joint, very mobile, fingers, only one direction, right? If you have multiple mobile joints, we're just going to collapse. So this would be my approach of creating stability and mobility together. So one is stabilizing something so that the mobility work can be done around it.
Yeah. Yeah. Do you have anything else in terms of recommendations for this, like taking the muscular stabilizing approach? Also, if anyone's got questions, throw them down in the chat, because we're coming to the end of the questions list that I've got. But do you have any more suggestions in terms of how to actually approach, like from a very practical, if I was going to go out and do this, how would they approach it?
So when it comes to hypermobile and EDS, I would prefer, if clients or patients, they don't start doing self-diagnosis or self-management, because it's a rabbit hole. It's very hard to find the end of. Okay. Yep. So the very first thing is find somebody who is very experienced in that field. 2, have very, very clear communication with that person, meaning be very, very open and in detailed with your explanation of what causing you problem, what doesn't cause problems, right? It's very important to express. So for example, there's a couple of jokes about, like, when you have EDS, everything rotates. True, but everything shouldn't rotate. So that's why the strength training comes in, handy, because we don't want everything to rotate. We want what's meant to be rotate to rotate, and what meant to be stable to be stable. Right, that's the reason we want to do strength training when it comes to hypermobility and EDS. The other approach is always a phase. I'm not going to go into the intricate muscles. So for some people, glutes and lats work really well. For others, glutes and obliques work really well. For others, adductor and obliques work really well. For others, abs and glutes work really well. But they only work for a short amount of time before you have to change it again.
Yeah.
So that would be the muscular approach. However, understanding what is happening at that time, clear communication with your clinician or your coach or your trainer, and develop a strategy for that period of time is very, very important. Like, I cannot stress enough, it's then and there. Just because you can't do something right now doesn't mean it's forever. It's just not right now. But if it's not right now, then don't do it. Do something around it.
Yeah. Something else I'd add, I guess, as well, from the mental, like a sanity perspective, when you've got EDS and you're navigating this, have an idea of, like, if you're a clinician or a coach or whatever working with these people, have an idea of where they're going, give them some kind of trajectory, because you can get really caught up in the muddy, I can't do this, I can't do anything. But have a clear idea of where they can go. But also do, like, if you, I've had this experience myself where I feel backed into a corner. I'm like, I can't do any exercises. And then I take a second and I'm like, actually, I can do these exercises. I just have it in my head that I should be really strong at these exercises. And actually right now I'm very weak at them. But if I do them at the weights that my body is saying is okay, I can do them, and eventually I can get strong at them. So let go of your biases of what you should be able to do and what you think you need, where you should be, and just where you are right now, knowing that doing something is going to get you forwards, but doing nothing at all is not going to get you forwards, if that makes sense.
Correct. Yeah, like something that you made mention in your post, regression is the way to progression. I think that's what you mentioned, right? And I love that approach, especially within the cohort that we're talking about today. Regression is sometimes the way to progress. If you fuck yourself up, you got another 4-6 weeks of not being able to do anything. I would much rather do a little bit now so I can do a little bit more later.
Yeah, and I just had this thing, like, I remember a while ago I started working with a bodybuilding coach, and he gave me this program. I looked at it, I was like, oh my God, I can't do this stuff. I haven't been able to do it for years, but me powerlifter couldn't do it, because me powerlifter has to lift huge amounts of weight. So I was like, you know what? I'm not going to let my coach down. I'm just going to do the movements, but I'm going to do them with no weight. And I was like, oh, I did that and it felt good. My joints felt really good afterwards. Next week I added a bit more weight. Next week I added a bit more weight. And then I was like, oh my gosh, I feel good. I'm feeling strong in this. And of course the Ehlers Danlos happened, as it does. And then all of a sudden I couldn't do some of those exercises anymore. And then I had to get different ones. But I actually had someone message me the other day with Ehlers Danlos, who used to be a high level Olympic weightlifter. And they're like, I can't lift more than 10 kilos now. This is doing my head in. And the advice I gave, and I don't know if it's helpful to them or not, but the advice that I gave was, don't think about the weight. Don't think about where you used to be. Don't think about how fast you want to get back to where you were. If you can do it unloaded, very short range of motion, very modified, with braces, with whatever else, but you can manage to do it pain-free, expose your body to the thing. I think exposure is really important. And like I know a word that you've used a lot, Shant, is robust, and like fortification and that kind of idea. And I think exposure is how we do that. And this is just with EDS in general, like it's easy to get yourself boxed into this corner where you can't do things, feel like you can't do anything. Small exposure is how you get to be good. But being picky about what those exposures are. Because the other thing that people are like, oh my gosh, how do you compete at such a high level in powerlifting? And it's like, they're like, I had to give up my sport. I'm like, what's your sport? Kickboxing. Okay, cool. That's something I've always wanted to do, but never been able to do. So it's choosing your battles. But I just think strength training is one of the best ones that you can.
Yeah. And going back to our history, if you remember when you're doing your bodybuilding, we had to periodize your posing.
Yeah.
Like we had to slowly introduce, and even with your, what is the maneuver you have to suck your gut in? Like we had to come up with a way to like lying on the floor, and we had to come up with a way for you to be able to do that. So you were able to do it, even though you couldn't do it standing up.
Which actually brings me to another point. So I think like I've done powerlifting, building at this high level. I think it can be, there's a lot of, not quite smoke and mirrors because I did this stuff, but it can be misleading to people who are like, oh my gosh, I can't even get out of bed and you're doing all of this stuff. It's like, I couldn't get out of bed either. People with EDS, sometimes there's these things that you can do that are up here, but you can't do the basic stuff. So if you measure yourself by, oh, I can't walk, I can't do the basic stuff, it is very disheartening, but often there's other things that you can do. And I think me doing the bodybuilding, probably from the outside, the whole Instagram's a highlight reel thing. People saw this, that I was doing this really high level stuff. There were days during the prep where I physically could not walk. I was hobbling around the house because my SIJ was so painful. There were days where I couldn't eat any food because my gut was playing up. But with these competitions, there's so many different things that you can manipulate to be good. Definitely with bodybuilding, to a lesser degree with powerlifting, but there's so many different channels that you can take. The small 1% things can really add up. So if you're someone who does have a goal, an end goal, like a competition or something more like that, be very creative with different channels that you take to get there. Like Chance said, come up with a protocol for my posing. I had to do my activation exercises before I posed. I had to do my activation exercises before I even did my cardio. Like there was there's so many different ways that you can get there. I'm just looking through the questions. We've got one here. Shant, when you talk about going through history for clients, what sort of questions outside of the normal screening questions would you consider including to cover potential EDS stuff, including the spinal blood pressure considerations? Do you do any screening for EDS?
So fortunately for me, majority of the EDS clients come from you. So I already know that they have EDS. So I don't have to do the diagnosis. But what I always look for, irrespective of whether you have, so my approach to anything is go in with a blank canvas. So that's why I tell people, do not send me scans, do not send me your, whatever the other physio or doctors have said. I just wanted to come in with a completely, I don't want to know, because I don't want anything creating a bias in the back of my mind, even subconsciously, that will affect my assessment. So when someone comes in, like I have an online client from New South Wales, and I could just see this guy standing, and like even when he's standing, his knees just like almost 30 degrees in extension. I'm like, okay, so we started doing a little bit of a movement assessment. I was like, immediately, okay, he has hypermobility, no question. So just by watching somebody move, you can pick up whether they have hypermobility or not. And for some to a degree. Working with somebody, like one of the examples that we use, which is watching a video of them doing a deadlift. Like everybody's like, oh, she should have gotten tighter. She couldn't have gotten tighter if I put a gun to her head. That's how elastic she is. That's all she's got. Right? What you see her lengthening is the elasticity that she has available in her body because of the hypermobility. So watching all those little things will give you an indication whether the person is hypermobile or not. Mm-hmm. And then when you start doing your test, you'll see the way that person moves. It feels very rubbery. It feels very bendy. Again, there's lots of people bendy. That's not the right solution. It's an information. You take that information. When you start asking them questions, so I have not come across one person that has EDS and I had to diagnose it, so I can't give you any information. Pretty much everyone, either they came through you or they saw me on your page and they came to me. So EDS cohort, they already knew they had EDS before they came to me. I did not diagnose it. It was just there.
And you said they're really on top of their symptoms. They're all really on top. They know how their body works. Like,
correct.
That's people is we know our bodies. We're smart people who sometimes this is doctors take it the wrong way because they're like, oh, this person knows all about themselves, do they? But it's actually really helpful information. Sorry to interrupt.
Yeah, no, so, and that's a very, very important point. It's about, like, again, clear communication with your clinician or your coach. When it comes to, if I know that someone's coming to me with EDS, especially if I know that you have referred them or they have come somehow through you, the best thing I can actually do, instead of me asking them question, I will let them lead the discussion. Because they will give me information I probably wouldn't have been able to think of asking, or they will lead me down a path that I wouldn't have thought about it, because they know their body so well. They have figured out their symptoms, their triggers, their little nuances so well that they will guide the consultation for me, which will lead me to do the right, precise, objective, or physiological assessments. Because now I don't have to do 20 different tests to find something out. They have given me so much information that I already have developed the pattern. Now, when it comes to hypermobility, especially the lower end hypermobility, I would focus more on what causes them, like, what do you struggle with? What causes them problem? If they're telling me something like, it doesn't matter how hard I try, I can't get tight. I'm like, do you think you can't get tight, or has somebody told you that you can't get tight? So many times, athletes have come to me because their coaches have told them he doesn't get, or she doesn't know how to get tight. And I look at them, I'm like, that's as tight as they're tightening up for their life.
But like, tight is so, I don't know. That's very interesting that you get saying this person can't get tight, because, like, what are we measuring tight by?
Correct. And okay, that's a pet peeve. I'm not going to go down that. We're going to have another half an hour rant, right? Like, stop saying tight, stop saying lats, stop saying this. Understand the movement, understand the direction, give them very, very specific directions. Pull your elbows down, pull your shoulders down, pull your shoulder blades back. Those are directions. Not say you keep your back tight, keep your chest up. They don't mean nothing. But again, going back to the questions, with the hypermobility population, generally, majority of the natural, your regular assessment questions will lead to the right direction. And then you'll start noticing the movement pattern that will give away even more information. With EDS, if there's one advice I can give, let them lead the discussion. They will give you so much information that you wouldn't even have thought about.
I'm just thinking of me asking. Like, I've got notes. I've got a page of notes here for you.
Yeah. And that's how we do our consultation. You already come up with, you have your notebook ready, you have everything written down for me. So I'm like, oh, this is easy. It's already been done for me. Now I know how to lead that discussion.
Yeah. So we've got the next question here. Could you go over again modifications for unilateral work? I get terrible hip shift and lateral hip tilts, and that's what I always get prescribed, but it's a trigger. The shift is in bilateral barbell stuff. So this person's getting bilateral shift in when they're doing bilateral barbell stuff, but then their physio or rehab person is giving them
unilateral lunges to fix that. Yeah. Okay. So So one of the things that I mentioned when it comes to hypermobility EDS, especially the female cohort, we are looking at avoiding unilateral movement, one, when the symptoms are present, two, during the menstrual cycle. Those are the two times we'll avoid unilateral movement altogether. I will not give them unilateral or extensive unilateral dominant rehab work either. It'll be more bilateral dominant movement, right? Because the unilateral, especially when it comes to lower body within that SI joint, it's going to create a lot of that mutation anteriorly and posteriorly countering to each other. So that can create the segmental failure, leading to pain. I will focus on doing more bilateral movements because that will create a lot more stability. Now, the other point about hip shift during barbell, it can be due to so many reasons, right? Because without a proper assessment, I can't give you an advice, this is the reason this is happening. It could be because you have one, like hip shift can happen for two reasons and they're contradicting each other, right? So one option is if you have one side weaker, your body will move away from the weaker side to the stronger side. So let's say you're shifting from your right side towards your left side because your right side is weak side and your left side is the stronger side. That's why you're moving towards that direction. However, the other reason can be you have more mobility in the right hip and you have less mobility in the left hip. So now you're trying to create more flexion out of that right hip and try to create less flexion out of that left hip. Now, when it comes to hypermobility and ADS function, so something that I mentioned, constantly maintaining articulation in the hip joint is very important. How you get there, it's going to be time and phase dependent. But we need to maintain all that mobility in that region so the mobility is not compromised and compensated through that SI joint.
Yeah. Yeah, it's an interesting one, isn't it? I think the fitness industry has really, like if you say to someone, how do you maintain balance side to side, everyone just goes into unilateral exercises. Just load the exercise up and do it unilateral. That makes sense because we're strengthening it and it's unilateral. Yeah. But no, and that idea, like coming from Stuart McGill's phrase, the proximal stability creates distal ability, in a metaphorical and very literal sense, looking at the nerves and how it actually, the body actually functions better when so the proximal stability is like, let's say in this case, it's the core strength, strength in the core creates distal ability, actually allows you to function better in your limbs. So it's a lot of the time the hip shift can come from not from the limbs at all. So why are we giving lunges, which it's going to strengthen your quadriceps and your hamstrings and everything on one side. But if it's like one of the muscles that people commonly say is getting used a lot in unilateral stuff is the glute medius. Well, if that's the cause of some of the issues, if strengthening that's going to fix it, why don't we do another exercise that's non-triggering? If someone's got the hip shift during a squat and then you go and put them under a loaded lunge, they're probably going to have the same dysfunction. It just won't be as visible. And you will still get the same pain presentation or even sometimes a different, causing a new pain. So I also like that approach. A saying from Andrew that I learned is isolate then integrate. So get that movement or that muscle group or whatever it is in a way that you can't possibly do it wrong and then integrate it. And it might be a case of doing some activation exercises before your barbell stuff. If you can do an activation exercise, then you do a barbell squat and you don't get the hip shift anymore. Okay, sweet. That's like, right. I'm stepping more into your territory.
Yeah, absolutely. No, so that's generally the approach. Like again, what I mentioned before, like the hip shift from right to left can happen for multiple reasons. The question is, we need to find out what is not working, what is weak, what is dysfunctioning. We fix that. If it's lack of external rotation through the hips, we fix that. If it's abduction through the hips, we fix that. If it's extension weakness through the hips, we fix that. Again, we have to be very, very precise in what we are fixing. And this is where activation, which is leading to the post-activation potentiation or post-activation performance enhancement, if you strengthen a muscle or if you activate a muscle in a specific direction that it's weak, it will enhance performance in a compound movement. If you're having a hip shift because you have weakness in external rotation through the hips, then I fix that through an activation protocol that isolates the hip in external rotation. Then I put you back into squat and the hip shift is not happening and you're not getting any pain at the front of the hip or your back or whatever the symptom may be. Okay, we have fixed that. And that is the protocol. We activate, we integrate, and we perform.
Yeah, to give some perspective for people who haven't worked with Shant, or the other physio we've mentioned, Andrew, when I've done some sessions with them, it's been like, okay, I'm getting pain deadlifting. All right, what weight do you get pain at? From the very first set, 60 kilos. Okay, let's put 60 kilos on the bar. Go and do it. You've got the pain. Okay, cool. Let's try this exercise. Okay, let's come back and do a 60 kilo deadlift again. Do you have the pain still? Yes. Okay, let's try this other exercise. Has that now alleviated the pain? And just going through things until you find the thing that helps. Like that can be an approach. Is if you're training yourself or working with a coach, that can be another thing that, okay, what are the things that make me feel better? But again, coming into what Shant said before about not self-diagnosing, but it's sort of a balance sometimes between finding the things that feel good versus not self-diagnosing, I guess.
Correct. So it's like have all the information and then find somebody who really understands how to interpret that information and come up with the right protocol for you. Right?
Yeah.
So it's you're vigilant about collecting information, but just not get paranoid about it. And don't try to fix things on your own if you do not have the knowledge for it, but have that information ready. So when you find somebody who is very knowledgeable or have a lot of experience in that field, they can use that information to give you the right path and the right protocol.
Yeah. In that case of, the physio prescribing the single leg work, it could even just be a case of coming back and saying, look, I've got this pain, it's triggering this problem, really firmly communicating it with them. And if they're not listening, finding someone else to work with, because I think that's especially important for EDS for several reasons that they listen to you. It's important for several reasons. Firstly, because as we've been discussing here, the symptoms that we have lead to the solution. Like, look how much Shant has developed his knowledge by working with these people and just simply listening to them and following the path of their experiences. It teaches you stuff. So it helps the clinician become better. So listening to the patient is important from that perspective. It's important because our symptoms aren't normal. Normal, I'm going to use that in quotation marks, because if you talk to people with EDS, we have very similar experiences. But so from that perspective, it's important. But also, I think from a very non-physical perspective, from a mental perspective, we get a lot of that through the system, people not listening to us. And I'm just at the point now where if someone just not going to listen to me, I just say, stuff it, I'll go somewhere else. Because I'm not going to put up with that anymore. People not listening to me and not taking me seriously, because I'm not a dumb person, and what I'm experiencing is real. So yeah. Now we've got another question regarding leg day recovery. I'm getting knocked out for a week afterwards. Volume and intensity and not extreme. Is there something you can recommend for recovery? Maybe a different approach. This one's tough. I would experiment with trying out different things. Maybe if you cut everything in half, and that's okay, then do that. And then over time, you can gradually increase it. This is a weird one because the fatigue and the recovery rates with EDS are a big thing. There's so many variables that we're dealing with here. So in the same way that what we've been saying in this whole video is, just because you can't do an exercise now doesn't mean you can never do it. But don't do it if it's causing the problem. I would say that same approach applies here. Just because you can't handle this much volume and intensity now doesn't mean you can never handle that. But right now your body can't. And do the thing that you can do, expose your body to little things leading up to being able to do more. This is a really common thing with EDS, because I've got friends and they've sort of gone through really bad, dark downturns with their EDS, and they said that they're so frail they couldn't go to get their mail out of their mailbox. And this is otherwise, I see them now, I'm like, you're healthy, you're training with me, and they're like, but that's how bad it got. And the way that you get out of that, I think, is small exposures don't make the problem worse. Do you have anything to add to that?
Yes, again, my answer to that would be, it depends. Like I would ask so many questions about that and really go down to get to the history of what led to that, what the program looked like, at what stage this started becoming a problem. Is it a phasic problem? Is it a gradual progression? Right. So all those things will lead to the right answer. So if it started happening out of nowhere, then more than likely you are having, lack of a better word, having a flare up. So you need to make sure that immediately you have to take the aggravators away. If it has been a gradual, then I will go down the rabbit hole a little bit more. Okay, is there one specific movement or one specific set on rep range that is aggravating it? Then try to play with that. Is it 3 sets of 12 causing the problem? Then what happens if you do 4 sets of 6?
Yeah.
So you're still getting a decent amount of volume, but having that, again, the fatigue factor, something that you mentioned, something I experience a lot within the EDS population. I can't just tell them, kind of get tighter, get to do. They don't have the capacity. It's beyond their physiological capacity. I just can't make them do it. There's nothing I can give them to make them do it. I have to modify their protocol, right? So for an example, with a lot of my activations, they have to do 25 reps. But with some of this cohort, I will say do clusters of 5. Do 5 reps and then have a 10-second rest. Do another 5 and have a 10-second rest. We're still getting our 25s. It's just taking a little bit longer because you have to do them in clusters. Because if you do more than one, it starts to create some compensation because of the fatigue factor, or it just starts creating a problem. But if you do clusters of 5 over, let's say, a minute, it's not a problem. You actually feel a lot better. So there's quite a few different things I would ask in that regard, like how did it happen? When did it happen? When did it start? What were the progressions? What were the program like before? Has it happened before? When did it happen the last time? Is it a common thing? Does it happen at a very specific time of the month? All those things I would ask.
Yeah, and I think actually coming back to the like a lot of the discussion that we've had about SIJ and EDS in general can be applied to this question as well. Like, for example, the triggers. What are some of your fatigue triggers? Are you actually getting triggered from outside of training, and then training is just the straw that breaks the camel's back? What are your other triggers? A big thing. A while ago, I wrote this chapter in a book. It's an academic book talking about the crossover between neurodivergence and Ehlers Danlos and hypermobility. And to create the content, I interviewed a couple of my friends who've got EDS, ADHD, autism, and the thing that came up, it was really validating. I'd been feeling all these things, but I thought that it was just all in my head, as we do. But hearing it, the exact repeat story from these different friends of mine who I look up to so much. I'm like, you do so many amazing, cool things. You're such a, I aspire to be you in a lot of ways. And then I was hearing their experience that, oh yeah, I have to choose sometimes between whether I'm going to work or whether I'm going to train because I can't do both in a day. I've had to cut back to part-time work because I can't handle it. My body just can't handle it. And the fatigue seems to be something that comes up when your body's like, we can't handle this at the moment. So look for other triggers. And again, I'm privileged in so many ways with my EDS. I've had medical parents who've helped me understand my body a lot more, which is huge. But also I'm working in this industry where I can choose my hours, I can choose what I do. That's a privilege that I'm unaware of. So if you're working full time, that could add into. So you've got to choose. Okay, do I want to stay working full time or do I want to improve my training? I'm crazy, so I'm like, nothing comes before my training. I'll live and eat whatever 2-minute noodles if I have to. Move back in with my mom and I can train still. Like that's my thing that I still do. But I want to just make it clear, me doing all this training is at the cost of other things. And it's an unfortunate thing with EDS that you have to weigh up which one am I going to choose. And it's not easy. It causes a lot of mental anguish for me and my friends who have this. It's not an easy thing, but I just want to make it clear that I'm not doing this and having it all. I don't have it all. I'm doing the training because I'm sacrificing other things. But if you've got kids, if you've got a family, if you've got other stuff that's fatiguing you, that's a really difficult decision to make. So maybe it's that your training has to go down a little bit until you have more capacity and things calm down here, and then you can increase the training up. as I said, the path will be different if you've got Ehlers Danlos, but it doesn't mean you can't do things, but it does require choosing and sacrifice, and we can't do it all. You have to choose, okay, which things am I going to do? So that's the other thing is when it comes to triggers, can you eliminate triggers? If you can't, okay, we need to bring the training down a bit. But still, something is better than nothing, and overtraining to the point that you're getting excessive fatigue is probably not actually giving you the results that you want anyway. So it's better to work wherever your body can actually work. All right, a couple more questions. On the bad EDS periods, deconditioning happens so fast. How do you cope with the constant battle of 1 step forwards, 2 steps back? I cry a lot. And that's how my dog and me crying is sort of the picture that comes to mind. But also, I just remind myself I've been through this before and I can get through it again. There's a saying I like, everything you can until you can do more, then do more. So sometimes everything I can means resting. Sometimes it means doing small exposures, as we've been talking about here. I'm lucky I've been doing this for long enough that I know the things, there's that concept called Pareto's principle, which is 80% of your results come from 20% of the work that you do. So I really just focus on those 20% things. What are the things that will move me forwards? I don't have to do 100% of the things. I'm only doing 20%. I'm reducing my capacity down. It might be 5% of things, but the 5% that I'm doing come from this 20% that are going to produce 80% of the results. So when I was bodybuilding prep, it was, okay, I'm going to stick to my diet. That's one thing I can do right now. I'm going to do my rehab exercises. A lot of my EDS mentality is I need to prepare myself to be able to do things later. So I'm low right now, but if I do nothing, then I'm just going to sink lower. So how do I maintain this and not sink any lower? What are the few things that I can do? And I'm lucky I've been doing this for so long. I've got that knowledge of what works for me. But yeah, I don't know if that helps. What to do when doctors won't diagnose me or shove it off as it not being a big deal? This is a good question. I like this question. My approach, this is my advice for anyone. Google search Ehlers Danlos doctor in your area related to a symptom that you have. So for me, gastroenterologist. I found an Ehlers Danlos gastroenterologist. Don't start with the GP. I don't know if you're in America, so I don't know how your healthcare system works as like compared to Australia, but here you have to get a GP referral to go see the specialist if you want to get it government subsidized. I don't ask the GP who should I go see. I do a Google search. I find someone who specializes in Ehlers Danlos and the particular symptom that I've got. I then book in with them, go to the GP, say, can you give me a referral for this person? I go to that specialist. If they specialize in Ehlers Danlos, they're normally a lot kinder, a lot more open-minded, and a lot more understanding. I then get that symptom treated, and I say to them while I'm in there, I'm really struggling to find doctors who will listen to me. Who can you send me to? From there, I get my referral network from that doctor. I don't get it from a GP. GPs don't know who to send it to if they've never experienced this. But go to the good doctors. I found my gastroenterologist. He was actually online talking in videos on the news and stuff, talking about how EDS is underdiagnosed. And I was like, this is the guy I want to go see. I've done this approach. I've only had one bad experience with it, which was a really bad heart cardiologist who basically dismissed me and told me that because I lift weights, I must not have Ehlers Danlos, and just he was rubbish. And I complained very vocally. And when I went back to see him, he treated me a lot better. So that's the approach I take with doctors. This one's for you, Shant. Is daily rehab recommended? Daily exercise and rehab aggravates my back. It's hard to balance.
Okay, so the first thing would be when it comes to rehab or activations, we have a rule twice a day, every day for the first 3 months, and then once a day for the rest of your life. That is very good for the non-hypermobile population. With the rehab protocol for EDS and hypermobile population, yes, we aim to do them every day. However, there are going to be days when you can't do them every day. Like I remember in your case, like there are days where you're just bedridden, like you're like, I can't even get out of bed, like let alone put a band around my knees, right? Okay, you are not going to be doing them because if anything, that's going to aggravate things. Number two, maybe have a review of the exercises that you're doing. Maybe they were useful before and they're not useful right now. Maybe they were not the right exercise to begin with. They just kind of managed the symptoms. There could be quite a few other things. Again, how precise was the assessment and how precise are the movement patterns? So the rehab exercises, if they're the right rehab exercises, generally they should not cause pain unless, again, I can't think of a better word, is a flare-up.
Yeah. I would also say sometimes the everyday is, for me, when I've done exercises every day, sometimes it hurts when I do every day, but every second day is okay. So I remember at one point we were kind of working with, there was 3 different rehab protocols that I had that I sort of cycled through depending on how my body was feeling that day. If I started this one and it wasn't feeling good, okay, I'm going to go to this other one, plan B.
Yeah.
That I've got plan C. So that's another approach.
Yeah.
Yeah. So this person who had the leg day problem, happens every leg day, can barely walk for it. Days afterwards, really neglected lower body as a result, low volume, moderate weight, but don't know my 1 rep max, so couldn't say. Another thing, I've actually just recorded a podcast, which I'm going to put out about this. The reps that you're doing, I prefer lower reps for people with EDS. How do you feel about that, Shant?
Yeah, hit the nail on the head. So when it comes to there's certain populations, actually, when it comes to EDS and hypermobility, another population comes to mind is women going through menopause. They have very similar physiological behavior as hypermobility, and I have a lot of experience in that field. And actually promised one of my clients, she's having similar issues, and I will bring this up in this podcast, which is when it comes to managing them, my favorite is 3 rep range when it comes to the compounds. I do not give them more than 3 rep range. You can do 5 sets of 3, but not 3 sets of 5. There are plenty of formulas that work for plenty of people, but when it comes to EDS, when it comes to hypermobility, or when it comes to postmenopause or into menopause, you need to be very cautious about making the program specific to them. Fatigue factor, joint laxity, lack of stability, segmental failure, they are all contributing factors. We manage them, we don't get rid of them. So you need to make sure we stay within a risk-free or minimal risk threshold. You want to start pushing the limit, you are going to find out some bad answers. So we always want to make sure, okay, if I can get you to do 87.5 for 3 reps, that means good chance I can get you to do 90 for 3 reps next week. That's a progression. That means I can get you to do 92.5, maybe for 2 reps, and then we go for 95 for 1 rep. I would much rather get to 95 that way rather than trying to do a bunch of reps at 80 and then just fail and then go back to the drawing board again. So 3 rep range when it comes to squat, deadlift, bench press, maybe it's one of my favorite rep range, and I will always play with that almost on a week-to-week basis.
Yeah, and I think to add to that, I think everyone's kind of got their rep range with the different movements that feels good. But what I would say is there's a principle that I use. We have to earn the right to do things. If you've got Ehlers Danlos, you have to earn the right to be able to train. You have to earn the right to be able to walk. You have to, like, our baseline is so much lower than most people's. So one of the big things in training that you have to earn the right to do is higher reps. You have to earn the right to do higher reps. If I've come back after a long period of detraining, I only do lower reps, even if it's for like a lat pull down, a lateral raise. I see people talking about higher reps for lateral raise. I don't do high reps for lateral raise because around that 14 rep mark, my shoulder feels really gross. However, if I do that exercise very consistently for a month or 2, maybe I can do a couple of sets. It's like a special treat that I reward myself with, this higher rep range, but I have to really earn it. It's not something that's just given. And that's a really bad misconception that exists in the fitness and rehab space, is that we have to do higher reps if someone's susceptible to injury, because then it's a lower weight. And higher reps and lower weight go together, and low reps and high weight go together. But what about medium weight? First of all, where does that sit? And also, we can actually do low reps with low weight and medium weight. And that's where I play with people with EDS. So if someone comes to me as a client and they're working with me and I'm giving them a session, I'm like, by the way, this might not feel like a workout for the first couple. It's not going to feel like a workout, but I'm preparing you to be able to work out. So that's another thing, actually. There's so many things. Like if we did a one-on-one session, we'd probably be able to figure out what it is that's making you so tired. But the reps, the rest, people talk about timing rest. I don't time my rests. I rest until I feel like either the pain goes away or the weird crampy muscles go away, or until I feel like I've got the lightheadedness goes away, the dizziness goes away, until I don't feel like I'm going to faint. Like there's so many things with EDS that you're resting from, not just, waiting until your 2 minutes is up. And that lower rep range also gives you a chance to check in with your body. You do the set, you check in with your body. You do the set, you check in with your body. So you get 5 check-ins with your body over 15 reps rather than 1 check-in with your body at the end of 15 reps if you do the whole set as 15 versus 5 sets of 3 like Sean said. Another question, is it common for symptoms to worsen with hormonal changes, e.g. pregnancy? Yes.
When it comes to hypermobility and pregnancy, you have to do a lot of management and maintenance work. I haven't had a lot of experience with hypermobility and pregnancy, but just pregnancy alone creates a lot of challenges and laxity, and that's the field that I have worked with a big cohort, especially during the COVID phase, because everybody was getting pregnant. So again, management, it's so important. And even within the pregnancy, the body is going to go through changes. The things you can do in first trimester, you're not going to be able to do on second trimester. The things you can do in second trimester, you won't be able to do on the during that third trimester. So again, you're going to go through the phases of what you can or can't do. But irrespective of what the mechanical or the objective side of things, I think one thing I always tell the cohort is, it's not never, it's just not right now. Just remember that. It's just not right now. There's always a way to get back to what we want to do, or how we want to get back to what we want to do, but it's just not right now. Right now, pregnancy is the priority. Let's focus on that, and we're going to do everything to work around that to be able to manage things the best we can.
The other thing I've noticed is there's, I've had quite a few people who are maybe they were always hypermobile, but they didn't realize it. Pregnancy brought it and they were left. They were fine before pregnancy. Pregnancy happened, and then now they're left with these catastrophic symptoms, which I'm like, hey, I recognize these symptoms. These are all my symptoms I've got now.
Yeah.
So that's another thing, is it can bring things out. And then like that just seems like a common trend that I've seen of women who were fine beforehand, then they fell pregnant, then the changes in their body plus the changes, like they've now got a kid and picking up a kid. I mean, that would trigger all of my symptoms as well. Yeah. So the triggers of change, and that can cause changes. Yeah. All right. I think we've gone for quite a long time, so we might cap it there. Thanks everyone for following, and thank you so much to Shant for sharing all this information.
Oh, I thoroughly enjoyed it. It was fun.
Yeah, it's been great. So last questions for you, Shant. If someone's got EDS hypermobility, how can they work with you? So for people who are listening who are physio, coach, or rehab specialists, do you do mentorships and do you help coaches understand this stuff?
So when it comes to EDS hypermobility, the scope of my practice, it's the musculoskeletal management. There's a lot of things that you have, there's nothing I can help you with. Like, for example, your sleep pattern or your, gastrointestinal issues or any of like that's not my domain. There's nothing I can help you with that. But when it comes to training, physiological things, musculoskeletal things, that's my domain. And that's what I work with. And I also work with a lot of coaches like yourself who have clients, so I can guide the coaches through the process. So even though they have done the rehab session with me, they still have questions, they're still figuring out how to write the program. I can guide them through that. So that's my domain. In terms of coaching, I do not coach as much. I very rarely coach. So probably that's kind of out of questions. It's like, it's a more personal interest or hobby for me, coaching. So I would say the best way I can help is the rehab and guiding coaches through rehab and in that phase.
Yeah.
In terms of mentoring and education, that's probably one of my biggest passions. I love educating. If anybody's interested, so I work with a lot of physicians, clinicians. We have even fortunately some doctors that are interested that are starting to work with me as well to understand things a little bit better, which is always good to see. I even have a surgeon who started working with me recently to understand movement a little bit better. So instead of just going for surgery, she can actually recommend their clients to do strength training.
Wow.
So any kind of mentoring, I would suggest the best thing is to just send me a message through Instagram and I will get in touch, because mentoring and education, I do not have, I will have a mentoring program coming up soon in the next month or so. It will be like an 8 to 12 week mentoring program. But individualized mentoring, I need to know what you want from me and what's the best way I can help you, so we can develop a platform for that.
Yeah, cool. Awesome.
Yeah.
Well, thank you very much. And thank you. Someone said this is the most information they've ever got for Ehlers Danlos. Well, yeah, to be honest, that doesn't surprise me, unfortunately. But there's going to be more. We'll put out some more information. And like I said, I've got that friend of mine who I mentioned who really understands the spinal fluid stuff and a lot more. She's sort of specialized in like the public health aspects of Ehlers Danlos. So there's some more resources there. But just send through any questions if you have specific questions or topics you want to cover, and we can either Shant and I can cover them, or we can cover them with whoever. But yeah, awesome. Thank you so much.
Perfect.
I don't know how to end this thing. Like, do I press exit? Do I?
You press the cross sign at the top, I think. Let's find out.
That allows me.
Thanks, Annie.
Okay. Okay. Thanks, guys.
No worries.
Bye.